How are you? I'm Dr. Shah. Today I'm with you with one of the most important topic in the clinical medicine, which is rheumatoid arthritis. And there are various strategies and various ways to deal with the rheumatoid arthritis. For the junior doctors and the young physicians, they must understand between what is just rheumatoid arthritis, what is seronegative rheumatoid arthritis, and what are the implications of seropositive rheumatoid arthritis on the patient, either male or female. So the diagnosis is very much important at the one aspect, and aggressive treatment is also important to make the life easy, to make the life free from any joint problems or morbidity. Let's suppose if you do not treat aggressively, someone within 5 to 10 years have advanced disease, and then many of the drugs may not work. So this is one of the important thing, that the first 6 months to the first 2 years are very important to arrest the disease, to decrease the inflammation, that the patient of rheumatoid arthritis definitely live longer without any serious consequences of rheumatoid arthritis. So these are just a very important highlights you may encounter in your clinical medicine, your exam perspective, but make sure these important headlines you keep in mind when you treat the disease. So this is very simple. These are the markers. Obviously, each patient is a different, not two patients are alike in the medicine. So I just made this highlight that what are the poor prognostic factors, or what are the markers in which rheumatoid arthritis is sometimes very difficult to treat. So number one, if there is a one antibody positive, let's suppose rheumatoid factor positive or just anti-CC positive low titers. Yes, but sometimes we do see very high titers rheumatoid, high titers anti-CCP active disease. When these two antibodies positive, it means the disease course will be more aggressive. And we do some a questionnaire, which I can discuss in some different setting, is a little bit lengthy. Health assessment questionnaire. If more than one, again, it's a poor prognostic factor. Generalized polyarthritis. Some people may have only 3 joints involved, maybe 2 joints, early disease, despite these are positive. But if these are positive, then you have more than 13 joints, 15 joints, all the MCPs are involved, all the PIPs involved, foot joints, large joints, small joints, crippled disease, at once severe flare and uncovering of rheumatoid arthritis. This will lead a difficult challenge for the doctor and the patient. So make sure when you think about, you don't go like just 7.5 mg methotrexate, just go and goodbye. No, it is not going to be helpful. Quick, more than one disease modifying, as I previously told, but we can discuss again. No issue, always, just to remind. Then extra-articular disease. There are many features, but I'm just highlighting 2 most important nodules. We always, or myself, whenever I examine, always look the rheumatoid nodules. This is one of the important stations you may encounter in FCPS, in MRCP, in a station to examine the hands, musculoskeletal. You can do everything and you can't see the nodules, this aspect behind the ears. Obviously, you can't see in the lungs in the exams, but obviously in the clinical settings, you may find the lung nodules. But the hand nodules are very important. Any rashes, any additional thing, vasculitic changes, anything urine dipstick, any other changes, that's also important. This is also a clinical or you can say laboratory parameters, persistently raised CRP and ESR. It means the persistent burst of the tumor necrosis factor, interleukin 6, and many other mediators are continuously damaging the joints. So this is important also to pick the right kind of the disease modifying drug, which we can discuss something in the future. Some kind of a rheumatoid arthritis people can have an additional ANA positive, which is also a poor prognostic factor. So sometimes you have to do ANA as well. So radiographic, this is very important, which I always highlight. Whenever you diagnose a case, do a baseline X-ray, hands, wrist, X-ray, feet, and ankle. This is the very baseline. Even when you diagnose the disease maybe a few years back started, you may find any erosion, so you will be more aggressive. So have a baseline X-rays for documentary purposes, and then you can repeat after 2 years, minimum after 2 years. And then HLA, obviously I don't do, and many even in the UK we don't do, except some research institute, Cambridge, Oxford, or some professors who can do further research. But generally we rheumatologists don't do this. This is maybe important. The countries, the modern developed countries, the people adhere to the drug, they do understand and they follow the treatment. But third world countries, if you discuss with the DMARDs or biological drugs, they may run away and they go to the Hakims, non-doctors, and then finally they can again come to you with such an advanced disease, then your drugs may not work rightly, and then they again not happy with you. So in this way, people who have a less educational background or less mentally understanding problem, then those people will suffer a lot. This is very important. Indirectly I can say a lot of people contact me and then they run away and they go to the either local doctors or XYZ, and then when the disease is, let's suppose, an advanced stage, then come back to, obviously not me, any other doctors. But that time again they are less patients, means patient need a patience. They want a magic things